Okay, so next I wanted to discuss nursing values and which ones you feel are most important to your position as a case manager and the care you give to your patients.
So I think first and foremost, you have to have integrity. I think you need a level of integrity with patients because that's what's going to drive your care. Um, in addition to integrity, I think that you should have compassion. I think that's a great big thing. And I think also that when it comes to nursing, we can't have biases. So we have to have that field of justice that everybody is created and everybody deserves care. I don't care about what your sexual whatever is. I don't care about what whatever you feel that's best for you and whatever you recognize yourself as and identify yourself as. Then as a nurse, that's what we have to do.
Right.
It's all about care because I don't want to do something that will impede the patient's care because I've said something and done something in a certain way. The patient clams up and cannot express themselves. So I don't want to ever be that type of nurse.
Great, that's a great point of view. What are some of the levels of care that are implemented in case management? So do you more so deal with the individual or the family or the community? Like how does case management interact with the level of care as a whole?
So with case management as well as with my current role, you deal with the patient, but you're bringing in resources, whatever it takes to get that patient to the next level in care with the optimal outcome. So you deal kind of with a little bit of everything because sometimes someone may need a resource for psychosocial help. Someone may need a resource for their kids. So you can't take care of the patient if you don't address the whole issue, and you have to look at the whole issue and address the patient in totality, and that includes just bringing everything into play with the patient, whatever it takes. I can't deal with the patient, and I know that I can't take care of a patient and that patient's worried about whether the kids can eat or not, or this, that, and so whatever resources that I have available, whatever I have, I try to give that to the patients and kind of direct them with care.
Okay. So types of technology or informatics needed to perform the role. I know you spoke a little bit about Allscripts. What type of programs do you use for case management?
So informatics, that's what drives the boat when it comes to care because everything is electronic. So you have to have some knowledge with informatics and how that works in the documentation process with patient care. There's certain programs, certain hospitals have certain programs. There's Sunrise. There is the new there's the LA program, which is a new one that my company is going with, Orlando Health is going with. Actually, they'll start rolling it out and they'll roll it out in sessions. So not the whole hospital won't flip over at one time. Each department's roll out in sessions. There's Allscripts that's used for documentation and some things as well. Then there is Varian or ARIA when it comes to the radiation side of it. All of their treatment or whatever they do for patients is documented in that system. So it's different systems, and sometimes the systems overlap and talk to each other. So you got to have the information correct in your primary system so that when it feeds over to the secondary system, everything is correct.
Okay. Health promotions and interventions that are most often used. So how do you help your patient reach optimal health in your role?
So how would I do that in my role? So we're going to use an example of a patient that's had a recent surgery that's been in the bed. So first of all, I need to optimize that patient by getting that patient into some activity. So then I'm going to suggest to the primary nurse or to the doctor, can we get a PT evaluation and just come and see what that patient can do? Then upon the PT evaluation, that will drive the boat as to what I will offer for the patient when it's time to discharge the patient. Whether it be in-home PT or be outpatient-based PT in a facility that's outside of the home. So it just depends on what we see, what you're dealing with there.
The next question I have for you, levels of diversity and multiculturalism, and I really thought this was a great question for you because cancer doesn't care about your race or your religion or anything. So tell me how you deal with the diversity and multicultural experiences that you've had in the position and how you take care of them no matter what their cultural background is.
So with that question, it's understanding the patient's culture, and honestly speaking, I have had to go back and look at a patient's culture, kind of read up on something about this culture, just so that I'm prepared when I know how to go in there and address a patient.
Absolutely.
When it comes to typically what we always know is the Jehovah's Witnesses. We know that they do not accept blood products. You know, that's just a bloodless transfusion. So I had to go back and study up on that, so I'm equipped when I handle that, when I come across a patient like that. And I understand their preferences. That's their preference. That's their religious preference. That's part of what makes them them. When it comes to other preferences and cultures, you look at certain cultures where the man is head of household, and you got the woman and you got the man in the hospital bed, but the man is head of household with certain cultures, so you have to take that into consideration as well. And I have to listen to him. And he may say something to his wife, but I understand that it's not personal. That's their culture. Their culture. Wife is not upset about it. To me, I would think, well, that sounds a little bit brash or harsh. The wife is not upset about it because that's their culture and she's accustomed to that. That's how they do. You know, that's what they do. And some cultures where the firstborns, the sons rule everything, you know, make the decisions, and there are no girls. The girls don't make the decision kind of like on anything. So you understand that too. You see patients as patients, and you respect the different cultures, whether it be Hispanic, be Haitian, Haitian Creole, whatever it is, Caribbean, whatever the culture is. You just respect each person's culture and identify with their culture what it is. I may not accept it from me personally, but it's not about me, it's about them.
Right. I definitely think what you said about going back and researching it is huge. When you get information that this patient has this background, came from this country, it's important that we research some sort of information about their healthcare practices, where they originated, and so that we can kind of blend that together. Exactly,
because that goes hand in hand. Somebody's religion may denote that they don't do this. Well, I'm not going to bring that to the board to suggest it, because I know that's against their preference and that's against their culture. So don't do that. Don't be offensive to the patient.
Right, absolutely. So the next question I have regards health disparities in your profession. So with case management, I know you deal with a lot of making sure that they're prepared to go home and they have everything that they need. What are some of the healthcare disparities you've seen, or had the challenges you've had, maybe homelessness or maybe
transgender homelessness? There's a lot of all of those things going on. There's transgender. So when it comes to me with transgender, I have to, like I said, identify that patient with what they identify themselves with. I can't go in there with my game face on, you know, my face on like, this is what, this. No, you can't do that.
Right.
You walk in there and you treat them just like you would any other patient that's laying in the bed. When it comes to healthcare disparities, that's a big thing in the country for us. Not everybody has insurance. Orlando has so many homeless people. So what happens to the homeless person when it's time to go home? They have come in there. Some patients you kind of inherit as a patient. So there are homeless people that come in and find out they have cancer, stage 4 cancer. So they've had all this surgery done because the doctor has to treat them. It's a public hospital. So what happens when it's time to go anywhere? So my role then becomes, okay, let me reach out to different entities we got within the care system. There's discharge support. There's different agencies that I can pull into. There's the REACH team that I can pull into to see what can we see if we can get this patient with some type of insurance. And sometimes it has been, they have actually, the hospital has actually come along and picked up a policy for the patient, because the patient's got to have treatment. The patient's got to have treatment. And I've seen that done in several instances. And you just, I cannot say that you can't have this just because you're homeless. Granted, the patient may have willed themselves to that. They may have done it to themselves. But I can't go in there with that type of mentality and attitude when it comes to patient care, because at the end of the day, it's still a human being, and I'm responsible for your life as long as you're on my clock.
Absolutely. The social determinants of healthcare that you feel help maintain it. So you mentioned that there's a high population of homelessness in Orlando, as well as a lot of people not having health insurance. Are there any other issues that you think, or social issues that you think, kind of impede us from moving, or impede us from handling the homelessness, or handling or attacking the situation without people having insurance? Like, what do you feel about that as far as social?
That is one of the main determinants when it comes to social issues, because insurance drives the boat with the care that you will receive.
Right.
You may need physical therapy, but with no insurance, what can I get for you outside of here?
Right.
I can give it to you while you're in here, but when you discharge, what can I get you while you're at? I can't get anybody to say, I'm gonna give you physical therapy for free for 2 or 3 weeks. That's not gonna happen in the realistic world.
Right.
I have had agencies when it comes to feeding tubes and that type thing, or NG tubes and that, not so much to NG tubes, but feeding tubes more or less when they go home with the bag, with the pouches, what have you. I've had companies that will take some of those people on and just provide them with a service. And you try to do, if I can get somebody to do that, it doesn't happen often, but sometimes it does happen. It can happen. A lot of times they take it to affect the patient's condition, history, and what's going on with them. There are people that have nowhere else to go but under the bridge. If it's a patient that's coming in new with a tracheotomy and is suction, I can't send you home under the bridge.
Right.
How you gonna suction yourself?
Right.
You can't suction under the bridge. So then I have to do my due diligence, reach out to the resources established within Orlando healthcare system and get that patient the appropriate help. Because I can't send you home with a trach that you can't suction, and you're gonna end up
dying. Right. Okay, so relevant public and or healthcare policies that exacerbate or don't address health disparities. Have you ever had to maybe discharge a person that you knew needed more care, but because of insurance or certain things like that, you weren't able to set them up for success like you would be able to if they were insured?
You see that a lot as well.
How do
You
you
see
handle
patients
those?
with insurance issues. I had a 33-year-old that really needed her anticoagulation medication, had no insurance, so then I had to reach out to the pharmacy. I called the pharmacy first to find out how much it would cost. Well, it would only cost $60 for a 10-day supply of medicine. She didn't have the $60 to put in, but I reached out to the pharmacy and said, well, what can we do? So I reached out to another entity for the inpatient chemo side of it. Can I get her a voucher? Luckily, I was able to get her a voucher. It took a lot of talking. It took a lot of pulling it together.
You do good at that,
but we was able to get her a voucher, and guess what? She got the medicine for the first 10 days. Now, what happened after the 10 days? I'm like, now listen, I'm gonna get you started.
Right.
I can get you started with
get her set up with what she needs, and then it's ultimately up to them to
it's ultimately up to her to keep it going from there.
Right.
And she was actually a young lady that came from a fairly well-to-do family, but she made some decisions in life that the mom and dad didn't necessarily agree with, so she ended up in a bad place. I could not judge her. That was not my intent. My intent was just to get her what she needed at that time to get out.
Good.
And then we have people that come in from the Department of Corrections. Sometimes those people, they come into, you have those people come in, and sometimes while they're there for their admission, the corrections officers, okay, our time is up, they're yours, and it could be somebody posted their bail, it could be their time served is up, but that patient then becomes yours. So then you're like,
so they just leave the
leave the patient.
Wow.
So then you got to figure out what's going to be best for this patient, and you're going to pray that it's nothing serious.
Right.
You're going to pray that it's nothing serious.
So, what are some ethical issues relevant to being a case manager?
When it comes to ethical issues, I think we have to be honest. More than anything, be honest, straightforward, and we can't sugarcoat an issue. You got to tell it. You got to see it for what it is, and you got to have honesty. There's got to be honesty. Also, there are patients we live in this day and age when there are drug-seeking patients.
Right.
So, ethically speaking, I've got to be on the lookout for those type of patients. Those patients too. I'm not going to feed into your frenzy by no means.
Right.
But you got to be able to distinguish between this and that. And there are some people that with chronic conditions, and one of the prime ones I see is our patients with sickle cell disease.
Oh yeah.
I know that the patients are in pain.
Right.
But because that stigma follows a patient, but they're an addict, well, they may be an addict, granted, but we've created that. The doctors have created that from when that patient was young and being treated with strong narcotics.
Right.
So we've created that. So ethically speaking, what am I going to do? Am I going to not, if you tell me your pain and I'm going to not address your pain, I got to address your pain.
Right.
I've got to reach out to your nurse, patient's pain, because when you go in as a care manager, that you're the one that come in there, so they don't think that you can just,
you can just do it.
You can just do it. I'm like, okay, so I'm not your primary nurse. but I can direct attention to your primary nurse. I can direct attention to your provider. I can send a message to your provider. You know,
Right.
you need to address this with this patient.
Right.
Some providers a little more freely understand it, and other providers you got to really put on that game face and kind of,
Absolutely.
I need you to do this. We're going to be professionals to each other about this. I need you to do this, and I need you to render this service to take care of your patients. So.
Right.
Mhm.
Absolutely.
Mhm.
Okay, so what are some legal parameters or constraints of the role? When is it too, like, what is the thin line?
The thin line.
Yes.
The thin line comes a lot when it comes to families.
Okay.
The thin line comes a lot with families, because you'll have somebody calling from up north that hadn't seen mom or in a long time, and you got somebody here, but yet that person may be
The proxy.
yeah. And then you got family dynamics there, so that's a bad thing. One of the most recent things we have, actually this happened back in January, with the healthcare proxy that was with the Orange County courts.
Okay.
But this lady was just this lady, and actually the judge actually pulled everything that she has, all the healthcare circuits that she was part of. The judge actually made them null and void because she was doing things against the patient's will.
Wow.
Mm-hmm. Doing things against the patient's
I
will.
think I saw that. Like,
You
on
would have
the
seen that on the
news.
news. She made the news.
Did.
She made the news, so we ended up having one of her patients,
Wow.
and it was
like she would make the patient a DNR despite the family.
yeah. That was an
Wow.
ugly situation.
That
Yeah.
is a legal
Mhm,
parameter.
mhm.
Wow.
Mhm.
So what are some public health policies that are relevant to your position? So